So thank you everyone for joining us today. In the aftermath of the George Floyd killing, many Americans became introspective about what it meant to be a racialized Black, white, or non-Black person of color in America, what their role was in this imbalanced social construct and contemplating ways to right the scales of justice. As a result, we created the series Dismantling Racism, Building Anti-Racist Psychiatrists to help bring awareness, education, reflection, and empathy to build a community of anti-racist psychiatrists. Today's event, A Treatment to Prison Pipeline, is the 12th installment in this series. We are joined by the authors of a newly published research in the Journal of Clinical Child and Adolescent Psychology that examines whether psychiatry is contributing to gender and racial inequality, not through the school to prison pipeline, but rather a residential treatment to prison pipeline. We intend for this to be a safe space to collectively share our complex thoughts and emotions surrounding these topics and brainstorm ways that we can come together to support each other, colleagues, patients, and the community at large. So I'd like to introduce our speakers for today. Dr. Shabnam Javdani is an associate professor of applied psychology at New York University. Her scholarship examines and disrupts the impact of persistent social inequity through community, policy, and system solutions that promote mental health, resource access, and self-determination for historically disenfranchised groups. Focusing on women, girls, LGBT, GNC people using a race equity lens, she engages research practice policy partners to study and change systems in real time and to advance substantial structural solutions that uproot complex social challenges with a focus on mass incarceration, juvenile, legal, and child welfare policy, persistent poverty, housing instability, and educational push-out. She has published over 75 manuscripts, and her scholarship is supported by competitive federal, state, and private funding. She is also director of the NYU Prison Education Program, which expands access to higher education among incarcerated students. Mackenzie Berezin is a six-year doctoral fellow in counseling psychology at New York University. Her research seeks to understand and reduce the multi-level impact of systemic inequity on youth through collaborative systems change efforts. Mackenzie's research supports local and national initiatives to disrupt youth pathways across child serving systems in partnership with court and community-based organizations through the implementation of gender and trauma-responsive practices and policies. Mackenzie also supports the work of local and international programming that aims to investigate the structural drivers of physical, mental, and sexual health disparities among adolescents and how they can be bolstered through community-based programming and policy change. She has published 11 empirical publications, 2 book chapters, and presented at 27 conferences to various academic stakeholder audiences to date. And our third presenter is Dr. Keisha April, who is an assistant professor in the School of Criminal Justice at Rutgers University in Newark. Her research, situated at the intersection of psychology and criminal justice, examines factors that contribute to racial and ethnic disparities in the juvenile justice system. Using mixed method approaches, Dr. April examines the attitudes and benefits of the individuals who interact with and work within the justice system to inform policies and practices to reduce disparities and promote more positive outcomes for justice-involved youth. She utilizes her interdisciplinary training as an applied researcher, clinician, and legal practitioner to devise ecologically sound and community-driven research questions. Dr. April's work has been published in several peer-reviewed journals, including the American Journal of Community Psychology, Journal of Clinical Child and Adolescent Psychology, and Children and Youth Services Review, and has presented at local, national, and international levels. We are pleased to have Ms. Berzin, Dr. Javdani, and Dr. April Freeman here with us today. First, with our program, we'll start with a brief presentation, and then we'll break out into two groups and have a facilitated discussion where we have questions to reflect on some of the topics that were raised in the presentation. During that presentation, we ask that spokespersons are designated to kind of sum up what we talked about in those groups when we come back to a larger group. And we'll repeat these instructions again. So now to our presenters, I'd like to give the floor. Thank you for joining us.
Thank you so much for, I was muted. Thank you so much for welcoming us into this space, with recognition for the fact that you all have created this space as an additional and necessary setting to discuss these really important issues. We see it, we appreciate it, and we're really honored and delighted to be here in conversation with you all. I can imagine from the different, just the titles and the roles that you all occupy. I'm sure that your plates for your jobs and all the additional visible and invisible labor that you might be doing in all different kinds of ways, your plates are full. And this is an evening to where we are discussing some tough issues, and we really appreciate the care that it takes to sort of to come together. And one of the reasons why we wanted to also prioritize coming and meeting you all and speaking with you all about this series of studies that we think is really important. So we're going to talk about this treatment to prison pipeline, and we think it's a great fit for this series that you all aptly named Dismantling Racism. And we know that this is part of the New York County Psychiatric Society, but we also recognize and understand that myriad healthcare providers and mental health care providers are part of care planning and see young people and families in crisis and in moments of treatment need. And so we have also geared our studies, our work, and our talk to speak to the workforce, the mental health, psychiatry, psychology, nursing, pediatric workforce at large. And so we're really delighted, and academic and research workforce as well, if that's part of another hat that you occupy. So I will be presenting the part of our presentation part, but this was a collaborative and integrated effort with Mackenzie Berzin and with Keisha April, and the paper that this study draws from is linked at the end of this presentation, and really delighted to give credit to Keisha and to Mackenzie as well for all their incredible contributions in conceptualizing and to really bring data to this issue so we can begin to unpack it. So to start, I want to provide a definition of structural racism that we have found useful in our work. And this is a definition that is provided by the Aspen Institute. I'm just going to highlight some key pieces of it. This is likely familiar to many of you. Structural racism is defined as a system or systems in which public policies, institutional practices, cultural representations, and other norms work in various and often reinforcing ways to perpetuate racial group inequity. It identifies dimensions of history and culture that have allowed privileges associated with whiteness and disadvantages associated with color, broadly speaking, to endure and adapt over time. To this definition of structural racism, we apply an intersectional lens, as others have before us, including from the root works of Angela Davis, Kimberly Crenshaw, who integrate other systems of subjugation and oppression, such as through gender identity and expression, to understand structural isms in combination with one another. And from this working definition, I want to bring to your attention an important distinction, and that is a distinction between disparity and inequity, which we often use interchangeably. So when we think about mental health disparities refer to differences in mental health status among different segments of the population, distinct groups of people, defined however we would like to define based on grouping. Whereas mental health inequity has a causal and explanatory element to it. Mental health inequities refer to disparities that we might see in mental health and health that result from systemic and avoidable and unjust policies and practices that disenfranchise distinct groups of people. So the inequity piece of mental health really is about the response of systems to mental health challenges or health challenges that folks might be experiencing, including in disparate ways. But the inequity is located at the level of systems, policies, and practices that serve to disenfranchise individuals and that serve to disenfranchise people in general. This framework is really nicely defined and outlined in an article by Shim from 2021, published in the American Journal of Psychiatry. If you haven't seen this article, it's a really lovely overview and a call for dismantling structural racism, with a call to the mental health care profession and psychiatry in particular. And so I refer you to that article, and I'm also happy to provide that article in the chat later if it's of interest to you. So working from this broad understanding of structural racism and mental health inequities, we wanted to focus on residential treatment centers, often also called residential treatment facilities, residential treatment care, residential settings that are meant to provide mental health care. The most oft used terms are RTC, residential treatment center, and residential treatment facility, but this is a broad umbrella. And our broad conceptualization is that RTCs may be a primary vehicle through which inequities are produced and perpetuated for young people who might be experiencing mental health challenges or who are perceived to be experiencing mental health and health challenges. And let me pause here and say that I will present on behalf of our team data from our studies and nuance some of the considerations that support this idea of RTCs as vehicles through which oppression might be instantiated. But if there is one takeaway that I would want us to be left with today, that takeaway is that residential treatment settings and facilities are not neutral grounds of treatment. They are consequential in ways that perpetuate social, health, mental health, and legal disparities, especially for youth of color and especially for girls of color and gender expansive young people of color. We'll try to unpack that a bit and show you a little bit about what the evidence suggests and where more evidence might be needed. But a big push for us to engage in this work was to really trouble the assumption that a residential treatment center is neutral or good, and try to understand the potential collateral and unintended negative consequences of young people engaging with residential treatment centers. So some things that we want you to know about RTCs that you might assume. Treatment is suggested in the name. However, there are no uniform standards of care across any RTCs nationally or globally. And that is according to reports as late as 2021, 2022, that have done surveys across different residential treatment centers and facilities and found no uniform standards of care, and nor do they mandate uniform standards of care. RTCs create disruption in community care because they are residential, they're essentially inpatient settings, and they are largely unmonitored in any sense of the word that you can imagine. RTCs are also growing in scope and scale, even though they represent spaces of confinement. And there have been multiple federal and national calls, including as couched in the important social justice movements that framed our introduction to this series. Those movements have called for decarceration or limits to youth confinement, yet RTCs represent spaces of youth confinement, and they are growing in size and scope across not just New York, but across the United States, and some evidence suggests also just globally. RTCs can exist as independent settings, standalone, private, independent settings, but they are most typically, in the majority of cases, an arm of the juvenile or family courts. That means something, and why we use the frame vehicle through which inequities can be produced and perpetuated. Let me say a little bit more about that. So a lot of our work is focused on the juvenile and family court structure broadly. And traditionally, the family court structure has had two buckets underneath a broad umbrella: a child welfare pathway or bucket that is meant to address neglectful or abusive caregiver dynamics, and then a juvenile justice pathway that is meant to address and respond to disruptive or unlawful child behavior. And those have been two of the primary pathways through which multiple feeder settings and institutions can refer youth or can connect youth. These can include schools, hospitals, community centers, right? But the courts essentially have had traditionally these two placement types of pathways within their umbrella. There has been legislation, including through the Juvenile Justice Delinquency and Prevention Act, to reduce the subjective discretion of family courts and states in being able to determine when and whether child welfare involvement can happen, and when and whether juvenile justice placement can happen, and especially laws that have been created that try to curtail and minimize how restrictive of a setting young people are allowed to be placed in, depending on the nature of the behavior that they are engaging in. As an example, young people under the age of 18 in most states can certainly be charged with delinquency offenses, which mirror those found in the adult criminal system: assault, theft, robbery, etc. But young people can also be charged with status-related offenses that are linked to their status as minors. These include offenses such as running away from home, truancy, not going to school, being disobedience. In the past, they have been called, waywardliness. In the very beginnings, they were just called immorality. And this is a way for us to understand historically the way that the family court system has enacted the principle of the state as parent when there is a need for the state to step in. Only recently, arguably in the past 5 to 7 years, do we see a residential treatment pathway or a mental health pathway, and under the umbrella of the juvenile and family court structure, primarily through contracts with agencies that operate residential centers. And the broad justification for young people being able to go into the residential pathway are that their mental health needs attention. Relative to the column you see on the left and the column you see on the right, mental health needs attention sounds like the lesser of all the evils, right? It has to us as well. And certainly many treatment providers would argue that mental health over punishment, or mental health over certainly family separation, right, is the right path to go. And this is precisely why research and attention is needed about this growing pathway under the umbrella of the juvenile and family court structure. Why is the juvenile and family court structure important? It is the #1 holder of resources for families who are who seek, request, want, and need resources. By far, in across public settings and institutions, the juvenile and family courts, your child protective service agencies, and so on, hold the most resources. And oftentimes a young person needs to be placed in one of these pathways in order for them or their families to be provided with the resources that are held by the juvenile and family court systems. So zooming in a little bit more, why do we focus on RTCs? Put very simply, overall, there is a lack of understanding of what actually happens behind the doors of the setting once youth, who are overwhelmingly youth of color, are referred to a residential treatment setting. Overall, there's subjective discretion as youth are referred for a variety of reasons. To go to an RTC, you do not have to have a child welfare case open. You do not have to have committed either a delinquency or a status offending kind of crime or behavior. You do not have ever had to have an arrest record. You do not have ever had to have a petition against the caregiver that indicates that that caregiver can't meet your needs. But a judge, a caseworker, a care team can suggest placement in a residential treatment center. And when they do so, it is mandatory in over 95% of cases. The most recent data in the United States show. So RTCs in these ways as well may represent a vehicle through which mental health inequity is instantiated in the name of treatment and as sanctioned directly or indirectly by health and mental health professionals. One of the things we learned looking deeply into some of our court petition data and talking with stakeholders who are involved in the family court system and that we have collaborated with over the years are that a mental health assessment, if a young person is actually lucky enough to have had an assessment completed and a written assessment provided in court, that has a recommendation at the end of that assessment, for instance, that says more intensive mental health treatment may be beneficial, right? That alone is a full and complete justification for a referral to a residential treatment center. And that is why awareness around what happens behind closed doors becomes extremely important, right? So the goal of our studies is to look behind those closed doors of residential treatment settings as best as we can. And with attention to, and here's where a big part of the structural racism and intersecting, sexism comes into play. A big part of looking behind those closed doors has to do with understanding the intersection between these RTC settings and systems of mass incarceration. Because we know that historically, communities of color and groups that have been subjugated or disenfranchised, especially families of color who experience poverty and who have experienced racial discrimination, limited access to resources and opportunity, oftentimes receive services upon the condition of surveillance. Think about the language of compliance, right? It means something different if a trained psychiatrist or nurse practitioner or mental health professional is thinking about treatment compliance than if a probation officer is asking about compliance when a young person is in a setting that is being monitored in some ways by the juvenile courts. And so looking behind the closed doors of residential treatment centers with a structural racism lens really requires us to ask what might be the legal collateral consequences, intended or not, of placement in these settings in the name of treatment. And so we were really interested in those legal consequences because we know that has already happened as a funnel from child welfare to juvenile justice to criminal justice systems. And so these two studies inform this question broadly, and I will go through some high-level methods and results Oh, so sorry to see you leave, and no worries. Thank you so much for attending. Um, so in briefly, our first study, we conducted a scoping review, and this was led by Dr. Keisha April. That utilize this systematic scoping review method to look at the overview of research evidence about the association between placement in residential care and legal risk. This included 18 peer-reviewed studies with about 28,000 youth and 77 staff and stakeholders, and they were conducted over a 20-year period between 2002 and 2022. And half of the studies were informed by the United States, and the other half were informed by the 3 other major areas that implement RTCs, the UK, Canada, and Australia. We did look at differences globally or not, and we're happy to talk more about those if that's of interest to you. The second study, we wanted to zoom in more closely. And this study was led by Mackenzie Barrison. This is a mixed methods analysis of case files that were coming out of RTC settings. So this analyzed all court petitions filed in one county over about an 18-month period to understand race and gender disparities. Essentially, for this study, what we were interested in for this 18-month period was the question, when young people receive any kind of an allegation of misconduct or juvenile delinquency, what do the petitions, the witness reports, the data say? What happened to make it so that a young person in treatment is arrested or has a new charge filed against them? Okay. And so, brief overview of our findings for study 1. Does RTC placement place risk for legal consequences, and for whom? We found broadly that, can you see the sub bullets here? Okay, perfect. That anywhere between 10 to 35% of youth are actually formally arrested or referred to the legal system through a legal allegation while they are supposed to be receiving treatment in a residential treatment facility. 8% of them had their first arrest ever in their lives while they were in treatment. Group residential settings were particularly risky and might be even riskier than inpatient psychiatric or therapeutic foster care settings. And that these young people were often charged with less serious offenses when they were in residential facilities. And they were charged with things like peer-related, property, low-level status assault offenses, and this was especially the case for girls. We also see certain factors that are related to which youth get arrested, and we see that arrests or petitions for offending are associated with common youth stressors, family, peer, staff, placement setting dynamics, expressions of powerlessness, distrust, or disrespect of treatment staff were typical. They were not outlier reports in the scoping review findings that reported them. And some thematic analyses of the scoping review suggested that these settings may create risky dynamics when the young people are there. Youth with varying needs are housed together in ways that may increase conflict or actually promote delinquency in different ways. Partly because these settings may be restrictive and punitive, and that staff are ill-equipped to respond to mental health needs and may rely on punitive responses. We know also that many staff reported wanting to call the police, needing to call the police in order to manage a crisis, despite the fact that this is a treatment setting. Some of the studies that reported this suggested that residential treatment staff do not have mental health treatment training. So this is obviously a really important barrier and a problem, and something that any community, any workforce referring to these settings should obviously be aware of in a really important way. So let me go through, because I see we have I want to make sure we can go into our breakout rooms. And so I will synthesize some of this at the end here, and of course make our slides available to you. But I want to support and elaborate and zoom out on these through our study 2 findings, where we looked at every court petition filed over an 18-month period and found that about 1 in 4 petitions were filed of all allegations made against all youth in an entire county were made against young people when they were in treatment, when they were in residential treatment. So if we just made it illegal to arrest or charge youth with delinquency when they were in treatment, we would cut down youth crime in that county by 25%. That's what our data show. Of all of those petitions, 3/4 were filed against girls of color. A huge inequity in filings that made us want to really zoom in, especially because most of these were child for misdemeanors, low-level offenses, simple assaults that could include anything from moving a staff out of the way to leave a common area into a room, to a threat of violence that doesn't rise to actual engagement in violence once youth are in the treatment setting. It's also really important for us to look at race and gender here, because a good proportion of the studies in the scoping review did not report on race or gender or both. Most reported on gender, majority didn't report on both race and gender, and a good proportion did not report on race. So we really wanted to take a look at this, and the majority of our petition sample were kids of color. So some thematic findings as we move into engaging in some of our discussion, from coding, the witness reports, the qualitative accounts that police officers made when a petition had been filed, victim reports in terms of what had happened to make police come and charge a young person with an offense or arrest a young person. Why? What were the themes around around why this was happening? One theme is that staff and youth, and especially girls of color, did not feel safe or feel like they had their needs met while they were living in residential treatment centers. They expressed not feeling safe, and importantly here, neither youth nor staff expressed a feeling of physical safety in these settings. Here's an example. A young person says, I felt like girls were going to do something to me. I got scared. I asked staff to walk me to my room because I wanted to tell her that I think they're going to jump me tonight. And I told the staff member. She told me to mind my business and stay in my room. And that's a young person who has had a charge filed against them, indicating this contextual reality. Youth also expressed not having and being criminalized for not having their needs met, even their basic needs met when they're in these treatment settings. Some examples of this, I later learned that she was an RTC resident, and besides the alcohol, she also stole a 2-pack of Clear Blue pregnancy tests, $30, and a box store of extra strength pain relief medication for $15. This might tell you a little bit about some of the resource needs that this young person is trying to meet. I walked out of the unit and went AWOL, meaning left the facility, to get away from these girls because I'm afraid they're going to attack me again. Knowledge and communicating this to the staff does not seem to create and promote a context of physical safety for these young people. A second overall theme is that there's a lower overall threshold for girls of color to incur legal charges and arrests while they're in residential treatment. And this may have to do with the subjective discretion that is involved not only in who gets placed in residential treatment, but also what residential treatment staff with limited training are considering and seeing as norm violating behavior. Think about who has attitude, right? Who is disrespectful? What does that mean? And how are our notions about that racialized and gendered in ways that result in young people's arrest? As I mentioned in the scoping review studies, in our study as well, girls were more likely to be charged with lower level offenses than boys. Half of girls' charges were for misdemeanor simple assaults. And there was a consistently lower threshold for justifying any kind of legal allegations for girls of color compared to boys, even for the same charges. So a lower threshold for girls to be arrested. A girl charged with assault, staff member says they want to press charges against that youth for pushing them and purposely spitting in their face. That's an example of a pretty high level of assault within that misdemeanor category for a girl. Here's an example of a boy charged with assault. He ripped down the shower curtain, removed the metal pole, yelled he was going to hit me in the head with the metal pole, and then proceeded to do so. These are different as a way to qualitatively show one anecdote of the differences in thresholds by gender. And then a final overall theme is that RTCs may seem to prioritize compliance over treatment in ways that trigger an escalated response, police contact, especially for girls of color. So this is a look at the setting of residential treatment. I think the data that we have peeked into so far do not suggest that this is a safety enhancing or a treatment enhancing setting. But in addition to that, there are punitive and compliance oriented dynamics concerned with regulating adolescents' behavior, clocking non-compliance, and then physical handling of young people who are seen to be out of control that lead to altercations and subsequent delinquency filings. This shows up in many different kinds of dynamics. Here is an example of that. A group of girls were socializing past visiting hours. One girl was charged for refusing to leave and cursing when staff attempted to remove her friends. Even though the girls eventually left the building through the fire exit, the supervisor locked the girls out of the treatment facility as a way to say, you can't do this, right? And an attention to trauma and the use of the primary way in which we saw the word therapy, treatment, therapeutic come up across all of these hundreds upon hundreds of petitions. And this was for the population of young people in that county, not a sample of them, the population over 18 months. The major treatment that we saw was through physical restraint, also called therapeutic holds, as a response to perceived non-compliance. This was in 25% of all of the residential treatment petitions. 86% were filed against girls of color. And so, and of these petitions, of these, none of them named a specific therapeutic intervention, a de-escalation of any sort attempted prior to the therapeutic hold, the physical restraint, which, as we know, is not a best practice in response to trauma and the trauma experiences that young people might have. It was so often in the moment of a physical restraint of a young person that a young person resisted physically, that resulted in the assault charge, which was that the assault happened when a young person was resisting the hold, the therapeutic hold. An example, Chelsea is a young person in crisis. Staff members attempting to calm her down along with other staff members. At one point, she attempted to choke herself with a shirt and bra, signaling self-harm, right? At this time, staff member intervened and another had her by the legs. That staff bent down to try to get the shirt and bra away. So she's being restrained by 2 to 3 staff people in this moment of acute crisis. Chelsea bit them, and there was an allegation and an assault charge filed that had to be handled by the juvenile courts. So I think that we can move over the synthesis for a moment and just go into a couple of recommendations that we gleaned from the literature. Obviously, an understanding of bias and structural treatment targets is necessary here, especially among supervisory and frontline staff within or interested in RTCs. Targets can include supporting staff's own mental health and skill development, youth treatment incorporating a socio-political lens, even basic understandings of particular responses like the therapeutic hold, escalating situations in ways that are extremely problematic, incorporating advocacy for young people. This can bleed into how we think about training and how we define the social problem of delinquency, of the right to mental health care, and how that mental health care gets implemented. So this can be about attending to and evaluating structural competencies, which I know many of you are familiar with in graduate programs and mental health disciplines, how we support and continue to support not just implicit bias, but how to see structural biases systematically implemented within systems, and how we can curtail those systems, not just by changing our attitudes, but by understanding that a referral to a setting like this, without having vetted the setting and understanding what the setting can do, can be extremely problematic and consequential for family. Some targets are here for your consideration, including promoting curiosity over compliance, increasing cultural competencies, and of course, diverse workforces who would get training on working with system-impacted young people, for instance. Public advocacy and other structural touchstones are certainly part of our next steps in the work that we do as ways to advocate against RTCs that don't demonstrate that they are interested in implementing or able to implement evidence-based treatments. And this can include what we essentially did in thinking about this paper and how to frame it, self-reflection as a field, recognizing our own roles and our own complicity potentially in reifying this particular pathway that can reinforce structural racism and can create more problems for families who, in the beginning, were simply seeking help and seeking resources. So I will pause there with an invitation for contact. Our contact information is here, as is the link to the paper from which we draw our data.